So as we know that next to DR, as in the sequence of this talk also, like it's vein occlusions are the second most common macro disorders which are seen worldwide. But before we start to treat these patients, you must always make sure that you identify the risk factors and take care of that also, so that you can save the other eye or prevent other multiple episodes happening in the same eye, other veins getting occluded. So this has to be given due care. So always see that you evaluate the patient as a whole and not only the eye. Here we see a case of a macular BRVO with a mild edema and relatively good vision, quite good vision. So normally, usually in a lot of patients, we do not take them directly to the table immediately. So a lot of times we tend to wait. So we know that approximately a third of the patients whom we see will not need treatment and resolve on their own. So when to treat, what patients to treat, and all these are some questions which we will see through this. The SCORE study report had shown that there was not much difference at the end of 1 year between the laser group as well as the transferon group. So they said that there was not much improvement in between these two groups, and both did more or less same. But this was for BRVO. But for CRVO, they showed that usage of intravitreal transferon gave a really good results, and people showed really good betterment of vision. More than 15 letters and all those things were seen in this. But so there was a lot of confusion on whether to use transferon in these patients, because you see that multiple injection in spite of that was not doing very well. But the recent trials with anti-VEGF drugs, that Cruz and Bravo, all these have shown that there is a definitive role of treating these patients. And so here we see that when to start treatment. So you see in one of the Cruz trials, people in CRVO, like when people shifted from no treatment to treatment, there was not as good an improvement as in eyes which were treated right from the starting. So this shows that as an indirect, it's not a direct evidence, but it's indirect evidence to see that any patient who walks in, irrespective of the duration, you better to start treating him if he has considerable edema and considerable vision loss. So no need to wait for 3 months like we used to believe earlier. We can write the first day itself, we can start treating him, provided he has got a considerable edema and less vision. So because this indirect evidence shows that treating them late may not give the same results as you would get by treating them immediately. So this is another case. You can see that the edema is more considerable, and there is also considerable loss of vision. Here we don't have any difference of opinion. You would normally directly take him to the theatre and give an injection. So how long to treat them and when to stop, and what are the criteria to use to decide, okay, well, let's stop now. So what are the things? So in this patient, first he came, there was a hardly very little edema, so we observed him. But when he came after 1 month, you can see that the edema is increased and the vision has also dropped. So we give him one injection of Lucentis, and this is the first month after Lucentis. You see that the edema is still not totally dry. So we give one more dose, and this is the second dose after 1 month. You see that there's a small amount of cyst here. Probably can stop here, but we was given one more injection. So we can try to keep on injecting till you get the best anatomical and best vision outcome. So this is what endpoint of treatment is. When you, after 2 or 3 injections, you feel that the vision is not improving any much, and you cannot have anatomical response as a strict criteria, because in a lot of patients you see that the anatomy is not coming down to normal, but vision tends to improve, especially in the branchial vein occlusion group, where in spite of considerable edema, you see that patients have really good vision. And and there is no recurrence, then you can think about increasing your gap between duration gap between your follow-ups, and also you can think about stopping treatment. So this is one of the studies showing the difference between vision and macular edema. So in this study they showed that OCT is not a correct criteria to assess vision in the BRVO group, but in the CRVO group, when the edema is more, vision is poor, when the edema is less, vision is good. But in the BRVO group, in spite of some eyes having a really severe edema, they had really good vision. So you cannot rely on OCT as a strict criteria for assessing your treatment outcome. So this is one case of in hemiceptal vein occlusion. You can see that the edema is slowly subsiding, and there is even some amount of residual edema even at month 4 after 3 injections. Probably the ERM is sort of a reason for this, but you can see that the vision is not improved at the last 3 visits. So at this point, you may think about stopping your therapy. You achieved your best visual outcome, and you may think of stopping. And if there's any further drop, you may think about retreating him, but probably you can start your initial course of treatment at this point of time. So how do you follow them for these patients? Usually we follow them every monthly. And after, like, if you have 3 consecutive visits of 3 visits or monthly visits, you see that there's no further increase or no further betterment without any treatment. You feel that there's no further recurrences. Then it means that these people can increase the gap between follow-ups, and the need for their further injection may be much lesser if they are symptom-free after 3 consecutive visits without any treatment. So how do you decide to retreat? So this is a patient of perfuse CRVO with macular edema. So after the first dose, he has come down to 6/9 and retina is totally flat. And after 2 months, you can see that there is some recurrence now. Vision has dropped. We re-inject, and again it has become flat. And after 2 months, again you have a recurrence, and then we re-inject. Again it becomes flat. So like this is the criteria given by Rajanarayanan and the LVPA group. So there is a sort of variation, lot of variation on this. So they retreated when eyes showed increase more than 500 microns in the central macular thickness compared to the previous thinnest measurement. And they retreated whenever there was a new or persistent cystoid changes or subretinal fluid, and when there was more than 5 letter loss in ETDRS along with increase in macular edema. So they also used this last criteria as a treatment because it shows that the vision is still improving. In 2 visits, 2 consecutive visits, there's an improvement in vision. So you keep on injecting till the vision becomes stable. So aim for the best vision you can get. So the first 3 criteria will be for the routine retreatment. Then comes the question, what agent to use? So we have so many agents with us now. We have the steroids, we have the so a lot of studies have shown that all these things are more or less equal. There are a lot of studies comparing Avastin with Lucentis, and the Geneva trial showed that Ozurdex also is quite useful. So the advantage is that in steroids you can increase the gap between injections is more, and you need lesser number of injections, but you have the risk of introducing cataract or glaucoma. So that's one of the things. And this is a sort of a comparative study done by Neil Bressler. He showed that aflibercept has the best efficacy as regards to when you consider more than 15 letter gained at 6 months, and next followed by Lucentis, Ozurdex, and the last is IVTA at around 27%. So currently in the US, aflibercept seems to be the best choice, but probably in India, Lucentis is good, and a lot of studies have shown that Lucentis and Avastin also equally, more or less work equally. So that also you can choose between these 2. So when to change injections? When after 3 or 4 injections you have no response, then you can convert to steroids using anti-VEGF, or if you're using steroids you can convert to anti-VEGF. Then this question again, the last talk also, there's a controversy whether to use single or combo. Again, we will not delve too much into this. Mahesh was telling that we should not give the wrong information about using combo treatment. But sometimes in our clinic we use combo treatment when there is severe edema. This is CRVO. We have a lot of edema. Avastin was given. We didn't achieve the response we needed. So we gave Avastin plus Triamcinolone combo, and you can see that it acts for a longer time. And with one single injection, we are able to achieve much more reduction. So sometimes in our clinic we use eyes with the SRF. When there's a lot of edema or a lot of amount of SRF, we tend to use sometimes combo treatment, especially in people coming with lower economical group, so that they can decrease the number of injections being given. But they can still say controversy. Then the question of dosing, how to give it as a PRN or a monthly. Most of the studies have shown that the monthly dosing is a good, but the Marvel trial again by Rajanarayanan and LVP group, they showed that PRN is also equally effective in Indian scenario. And in spite of PRN dosing, also the need for giving laser treatment also not very much. So even in BRV cases, PRN based treatment also is helpful as equal to a monthly treatment like done in the Western studies. This is a case example where a patient is a 70-year-old patient who has undergone surgery for a heart disease, and there is a leakage with heart exudates. There is a small tributary retinal vein occlusion. So this patient we could not give anti-VEGF, and he had a glaucoma, so we could not give steroids also. We did laser, and the edema did not become flat, but his vision remained stable, so we didn't further treat him. So when to add on laser? Again, the data is not very conclusive both for CRVO as well as for BRVO. So here mostly in our clinic we prefer laser along with in cases of BRVO where there is lot of leakage seen in fluorescein, not in fresh cases, in old cases where there is a lot of leakage. But the Cochrane analysis has shown that the role of laser in BRV was still very controversial, and there is no clear-cut guidelines as regards to. In CRV also, it is not very clear-cut. I mean, there's no proven rule. In BRV, even though clinically in our practice we are using it, there is no strong evidence to suggest that this is useful. There's one more case where we see that how long to treat these patients. So this patient lost the left eye because of CRVO, developed NVG, and the right eye again he developed a CRVO. And we have given so many injections in the last 5 years, 4-5 years. So a total of 17 doses and 3 doses of Avastin. So now we developed glaucoma also on treatment. So he got fed up, we got fed up. Then finally he was so upset that we went in for a vitrectomy. And even after vitrectomy, even though there was not as much recurrence as we saw earlier, still he had some multiple recurrences. So even though it was CRVO, I went for a grid laser, and we could achieve a much more dryness than we achieved by the plain vitrectomy. So these are all still controversial, when to do laser, when to do vitrectomy. So the duration, like in the retained study, they shown that even at the end of 4 years, more than 50% of the patients will still need treatment. So this is a sort of a lifetime follow-up like we do in AMD. Just because it's a vein occlusion, it doesn't mean that it's going to be a short course. So always you should explain to the patient that there's a chance that it's going to be a long drawn affair. So in patients with already a lot of atrophy and where there's a lot of ischemia, sometimes you may not be doing well by treating them, because you're not going to achieve much by injecting them in these scenarios. Thank you.